The next talk is actually a full presentation, Predictors of Adherence to Antihypertensive Therapy among patients treated for acute type B aortic dissections, given by Dr. Brooks and his group from University of Utah.
Hello. I want to thank the VESS Program Committee for the opportunity to present our data at the winter meeting. And in the spirit of a live VESS meeting, I've worn my ski attire. We have no disclosures to report. Type B dissection is the most common acute event affecting the descending aorta, characterized by an intimal tear with blood tracking within the media and resulting in a false lumen. While immediate surgical therapy is reserved for patients with malperfusion, medical management is a standard therapy for all patients with acute type B aortic dissection, irrespective of complications. The mainstay of medical management is anti-impulse therapy, which is focused on reducing aortic wall shear stress and the change in aortic pressure over time, also expressed as dP over dt. This is most effectively accomplished using beta blockers as shown here, with the addition of vasodilators to further reduce blood pressure as needed. As such, most patients with type B aortic dissections are placed on a combination of beta blockers plus other agents with vasodilator properties to achieve these combined effects. This may include blood pressure lowering agents within these 6 different classes of medications, including beta blockers, ACE inhibitors or angiotensin II receptor blockers, diuretics, alpha blockers, calcium channel blockers, and vasodilators such as hydralazine. Professional guidelines consistently recommend that these blood pressure reducing agents be started on all patients with acute type B aortic dissections, particularly for uncomplicated patients who are not undergoing any surgical intervention. This is regarded as a class 1 recommendation, despite the lack of evidence from randomized controlled trials. The question is, are these guidelines being followed when patients leave the hospital? The objective of this study was to determine to what extent patients diagnosed with acute type B aortic dissections are adherent with outpatient antihypertensive medical therapy and to identify predictors of medication non-adherence. We used data from the Truven Market Scan database between 2008 to 2017 to identify all insured adult patients who had prescriptions filled for antihypertensive medications following an acute type B aortic dissection. Market Scan is a nationwide database that includes healthcare claims from over 30 million policyholders with commercial or Medicare Advantage insurance, along with their spouse and dependents. Patients were excluded from our analysis if they had billing codes associated with type A dissections, any history of prior aortic dissections or aneurysm repair, or if they did not have insurance coverage for at least 1 month before and 1 year after their diagnosis of aortic dissection. This left a total of 6,702 patients, of which 4,952 were treated with medical therapy alone. 231 patients underwent TVAR plus medical therapy, 576 underwent aortic open surgery plus medical therapy, but 943 patients had no claims for either their surgical or medical treatment following an acute aortic dissection. Among patients who received in this cohort or prescribed any of these 6 different classes of antihypertensive agents, medication adherence was calculated using the proportion of days algorithm, representing the proportion of days an individual had prescription medication available from their index diagnosis of acute type B aortic dissection through the number of days in the study time period. Adherence was defined as the proportion of days that was covered greater than 80%, which aligns with current standard definitions for adherence. To assess factors influencing medication adherence, we ran a mixed effects logistic regression analysis for all antihypertensive medication types, using the patient as a random effect and predictor variables as fixed effects. Predictor variables in this analysis included patient demographics and comorbidities as shown here, as well as variables specific to their antihypertensive medication usage. This included the number of agents patients were on, the class of agents they were on, days of prescribed supply, the type of pharmacy they got their prescriptions filled at, and whether their antihypertensive agents were fixed or variable dosed. The study population is shown here, stratified by primary treatment used for the acute type B aortic dissection. As you can see, in general, patients who are only treated with either medical or surgical management for their aortic dissection were fairly balanced in terms of demographics and comorbidities. In comparison, patients who received no therapy were younger and had fewer comorbidities overall. For patients who receive medical therapy, the most common classes of antihypertensive medications prescribed following an acute type B aortic dissection were beta blockers, ACE inhibitors or angiotensin II receptor blockers, or diuretics. Most patients obtained their medications from a retail pharmacy and were on at least 2 or more blood pressure lowering agents to maintain strict blood pressure control. Overall adherence to antihypertensive medications was nearly 82%, and while it was slightly lower for patients who underwent a TEVAR, adherence was slightly higher if patients underwent open surgery. In mixed effects regression models, we found that female patients and those in younger age groups were significantly less likely to be adherent to antihypertensive medical therapy after an acute type B aortic dissection. However, living in a rural community did not seem to matter. In terms of specific medications, patients prescribed more than a 45-day supply of medications, specifically beta blockers, ACE inhibitors or angiotensin receptor blockers, or calcium channel blockers, were all found to be significantly more likely to be adherent to medical therapy. Conversely, patients with hypertension who are non-adherent to blood pressure medication use before an acute type B aortic dissection were significantly less likely to be adherent. And there was no effect based on how many different medications patients were prescribed overall. So in summary, nearly a fifth of patients in our study were non-adherent with antihypertensive therapy following an acute diagnosis of type B aortic dissection. Non-adherence was more likely among younger female patients and those who were non-adherent before their dissection occurred. Further, our data suggests that adherence is improved when patients receive an extended supply of their medications by mail. Clearly, it's important to identify patients who are high risk for non-adherence and failing non-operative medical management for acute type B aortic dissection. Improving adherence to antihypertensive therapy and promoting strict blood pressure control following an acute type B aortic dissection can prevent further aortic degeneration and all associated complications. Thank you again, and I'm happy to address any questions.
Thank you for that important work. And this paper is now open for questions and discussion. Actually, I will start. Among the many things I wanted to ask you, one thing that's come under discussion is who is actually responsible for the medication and the compliance in this very sick group. Is it the primary care doctor? Is it the surgeons? Do you have any sense in your study and also in your own practice how you have shared this responsibility or taken it over?
Thank you. I think that's an excellent question and something that we all struggle with for a lot of different conditions, whether it be treating patients with anti-impulse therapy or giving them a statin after a major vascular procedure that we're all graded on in terms of our VQI adherence to those medications. But typically, I think our role is to ensure that they're on these medications at the time of discharge and when we see them back in clinic. But ultimately, we need to pass this off to the primary care doctors who are really going to be managing their chronic medications and following them for longer periods of time, and I think have more points of care or touch points where they can ensure that these medications are being they're being compliant or adherent with. The real question is, how do we communicate to the primary care doctors to ensure that this the importance of being on these medications is understood? Because I think sometimes, particularly for statin therapy, for example, a lot of PCPs don't understand why we're prescribing them. They might check a lipid level and that it's fine, and they don't understand the platelet mechanisms. And then with anti-impulse therapy, I think it's understanding what our goals of care are in terms of lowering their blood pressure to an acceptable range. I mean, they might feel like having blood pressures in sort of a pseudo hypertensive range is okay, whereas we might feel strongly about titrating those medications and making sure that they really get down to a point where they're not at risk of having complications.
Mm-hmm. Thank you for your response. Now the questions are flying in, so I'm just going to get started. The first one's from Dr. Jason Lee, who says, "Great project, Ben. Should we add likelihood to fail to adhere to a high risk criteria and consider more aggressive TVAR at the initial presentation?"
That's an excellent question. And our study was not necessarily to look at how TVAR was used as a therapeutic modality for this project, but just to look at the actual blood pressure management after TVAR or a non-operative approach. But certainly just because we treat somebody with TVAR doesn't mean that we want to stop their blood pressure control. And I think that's kind of one of the things that sometimes some people might misconstrue, is that a patient comes in with a type B aortic dissection, they get a TVAR and they're fixed, but they're really not fixed, and they're at risk of having either propagation or other segments that degenerate and become aneurysmal. So I think that's something that we need to be thinking about.
Mm-hmm, mm-hmm. Another question from Dr. Rajani. Any idea what your compliance rate is if you include uninsured patients as well for a more real-world assessment?
Excellent question, Dr. Rajani. And we were looking at a data set that only included people with healthcare insurance. And so I would obviously assume that the compliance is much lower, because unless they're getting their medications through some sort of program to happen, most of those patients are really at the highest risk. And it's hard to follow those patients and really know what the true outcomes are when they're not given any medication. I think one of the things just to point out with our analysis is that we actually found a fairly high number of patients who had an acute type B aortic dissection who, despite having insurance, received no medical therapy. And so that's the other question is, there was at least almost 1,000 patients who, despite having a condition where, medical therapy is warranted, they were not prescribed any medications to help treat that once they left the hospital.
Mm-hmm. And do you know, in that group who needed medication but was not prescribed any, were they evaluated by a surgeon?
Well, we would assume they were, because they, okay. I mean, again, this is a claims data set, so we're looking at, whether they had a diagnostic, ICD-9 or 10 code. Mm-hmm. But we didn't specifically look to see, there's no way of looking to see if a vascular surgeon had evaluated them, but I would assume either a vascular surgeon or a CT surgeon had.
Got it. The next question is coming from Dr. Sukal. Great job and very informative. Can you tell from the database if those patients who were more adherent had lower rates of readmission or reintervention for their dissection?
Excellent question, Bjorn, and that's a focus of our next analysis. We were now looking to see if the patients who were non-adherent or had not received any medication, if they had a higher rate of reinterventions over long-term follow-up. So the one thing that's nice about MarketScan is that you can follow patients as long as they have the same continuous insurance. You can follow them out 5 to 10 years, and so that's what we're looking at. Because a lot of these patients, they might have a lot of adherence early on, but we're looking at also long-term adherence and how that relates to complications. Mm-hmm. And so the main thing is looking to see if they had a reintervention.
Mm-hmm, mm-hmm. The next question is coming from Dr. Parth Shah. Thank you for sharing your experience. Have you looked into wearable technology, understanding the inherent bias and its impact on compliance?
Oh, interesting. I had not thought about that, but I think that's certainly something we should all be thinking about going forward, not for anti-impulse therapy, but like all medication adherence, and how we can use technology to understand, patient compliance and adherence. I know I've heard of some other studies where people have been testing some things where patients receive their medications at home. They can actually, it will monitor and sort of alert the prescribing provider when they have an open up like the box to get their daily medications, and how that could sort of a feedback loop. But again, I think we're probably years away from really seeing that used in a sort of common everyday practice.
Mm-hmm. My co-moderator actually has a question. So this is from Dr. Hicks. Market scan is limited to patients under the age of 65. Do you think your findings generalize to older patients presenting with dissection?
Well, so market scan, actually you can, the market scan that we have actually has Part C claims, which is the Medicaid or Medicare Advantage. So it's a more select group of Medicare beneficiaries. And it was, it's a smaller cohort in terms of the whole population that we looked at. I think it was only like, 15%. And, the Medicare Advantage patients are those that traditionally have dual coverage. And so they're more affluent, or they've got, they've got private insurance plus their Medicare. So it's not always like considered the best Medicare group to be looking at. But despite that, we did use a reference group in our analysis of patients greater than 65 years. And so, what we found, the patients who were in the younger age groups, as we stratified them, were increasingly more non-compliant. So those were in the 18 to 24 age group were actually the least compliant of any of the age groups that we looked at.
Mm-hmm. Well, Dr. Brooks, I think there's something like 10 more questions on this list. Maybe we can just end with this very last one, and hopefully you can get to all of them in the different platform. This one's coming, the last one's coming from Dr. Kemp. I love the last point. She says, it's straightforward, provide 90-day supplies. Is there a downside for vascular surgeons going ahead and doing this?
I don't think so. I think it's a good point. Is to sometimes we get in this habit of just saying give them a 30-day supply of medications, but why aren't we giving a 90-day supply of medication that we feel like is going to be critical? And sometimes we don't know when the patients are going to actually get to see their primary doctor to even get the refills. I think the other point of this analysis that we found that patients who get their medications by mail actually have increased adherence, which was another thing that I thought was kind of interesting. And that, now there's a lot of, these online pharmacies. In fact, Amazon just bought a company called PillPack that's located in Salt Lake City that is sort of an online way that patients can get their medications delivered, automatically. And it just kind of reduces the chance that, there might be some reason they can't get to their local pharmacy, and, it just automatically comes and is delivered to their door, on a monthly basis. So I think, thinking about these newer generation, mechanisms and strategies for ensuring that our patients are getting their medications is something that we should be all thinking about.
Well, that was a wonderful presentation, and I think it generated a lot of thoughts and ideas for us as a group. So thank you so much for your work. And like I said, there's more questions, so please continue the conversation. Sure. I'm going to turn it back to Dr. Hicks.